Right, so today we are continuing our discussion on histology of cardiovascular system. Right now, we will concentrate on the histology of heart, right? And when we talk about the heart, like rest of the cardiovascular system, heart also has three layers, right? Innermost is called endocardium, middle layer is myocardium, and outer layer is pericardium. Let's suppose that here is your heart, and now the point which you have to understand, this is the inner lining of the cardiac chambers, and this blue lining is basically called endocardium. Endocardium is somewhat like intima of the vessels. It is like intima of the vessels, endocardium, and of course valves are made of connective tissue. Valves are made of fibrous connective tissue. Now look, actually this intima is, or endocardium is lining all the chambers, including the both surfaces of the valves. And you can see that this intima, endocardium, continues in the vessel with the vessel's intima. Suppose this is the intima of aorta, and over the valve then it continues with the endocardium. In the same way here also endocardium is lining over the valve structure as well, and here endocardium will become continue with the intima of the superior vena cava and inferior vena cava. And you can see that of course here also you can see over the pulmonary valve again it become continue with the intima of pulmonary artery. And here is your beautiful myocardium. Myocardium is the main muscular layer, right? Myocardium of one point which is very important, and I will illustrate later, that myocardium of atria and ventricle is not continuous. You know, atrial myocardium and here is ventricular myocardium, they are having they are separated from each other by fibrous tissue. Is that right? This is all your myocardium, and especially you have to remember myocardium of the left ventricle is more thicker than the myocardium of the right ventricle, because left ventricle has to push the blood into high pressure circulation, which is systemic circulation, right? And right ventricle has to push the blood into low pressure circulation, which is called coronary circulation, right? And outside that, right outside the myocardium, there is a special layer of connective tissue, and this is making a sac around it, and this sac is called pericardial sac, right? This is your pericardial sac. Now, please. This is connective tissue, fibrous tissue, and especially if you want to study pericardium first, okay? In the pericardium, we'll start with the endocardium first, then we'll study the first endocardium, then myocardium, and then pericardial sac, right? to tell you exactly the structure of the heart, this is one way to look at it. You know, most muscles in the body have certain points where they have insertion, where the myocardial muscle is inserted. Yes, Dr. Byagne is telling us that myocardial muscle is inserted where? Yeah? Fibrous skeleton of the heart. That's great. That is inserted to the fibrous skeleton of the heart. So let's first of all look at the primary structure on which all the heart is mounted. The primarily, okay, let me tell you, there's a fibrous ring. There's a fibrous skeleton of the heart, right? The heart doesn't have bones. Even some people have such a hard heart. Maybe they have it, but most of the men or women, they don't have bones in their heart. They have only fibrous skeleton to which the cardiac components are attached. Let's suppose I draw the cardiac ring, fibrous ring first. This is the fibrous ring, right? And there is left side of the heart on that side. This is the left side of the heart and this is right side of the heart. Now, here is your, there are on each side there are two apertures. Now, listen. What is this? There is a big fibrous ring in which there are four apertures, right? This is the area for the mitral valve. Mitral valve is mounted over here. This is the area for aortic valve. This is the area for tricuspid, and this is the area for pulmonary valve. It means this is the basic structure, right? This is a very strong rings, and this fibrous plate or fibrous ring, right, having these four main apertures. Now look at here, it will help you to understand the cardiac anatomy very easily. Look, on this is the mitral valve. You remember that left atrium was pushing the blood through the mitral valve to the left ventricle. So over it, what is this mounted? What is this mounted over it? This is? No. Yeah, this is left atrium, which is mounted over that. And here what is mounted? Left ventricle. Is that right? And what is this going out? Aorta. Is that right? So this is one way to look at the exact, that left atrium is mounted on the annulus ring of mitral valve, and aorta is mounted on the annulus ring of aortic valve, and whole left ventricle is mounted around left part of the ring. Is that right? Then we come to the right side. If I draw the right side with different color, this is the right ventricle. Is that right? Then what is mounted here? Right? Atrium, that should be mounted over this. And this is the ventricle, and what should be coming out from here? Pulmonary artery, right? I will again draw it. Now you will tell me the structure. If I draw only the left side, this is the mitral and this is the aortic. So you have, what is this structure? Yes. And what is this structure? And what is this structure? Right, so blood is coming like this from the lungs, passing through this to the ventricles, and through the ventricles, through this, going to the rest of the body. Is that right? And now you will again rapidly tell me. Yes, on this ring, what is mounted here? And what is here? And what is going out from here? Pulmonary artery. Now you may be thinking, why I put so much clear concepts, why I am concerned about it. The reason being that when you will go to higher classes, you will find that this concept has a lot of implications clinically. For example, attention please. If any disease which lead to left ventricular dilation, left ventricle dilate, then whole this part of the ring will be stretched out and mitral valve and aortic valve will regurgitate. You are understanding me? Again, let's suppose that this is the mitral ring, this is the aortic ring. Under that, what is there? Left ventricle. If left ventricle stretches out, both rings will stretch out. When both rings will stretch out, suppose this is the mitral valve. This is the ring of the mitral valve. When ring of the mitral valve stretch out, then when my left ventricle contract, it should close. But if it is stretched out, it will avert. Can it work well? No. So basically what happened, that if left ventricle stretches out, whole this area will, this ring, or you can say this ring will stretch out, these valves cannot work well. In the same way, if right ventricle stretch out, then these valves cannot work well. Is that right? So what did we learn here? We learned about the fibrous skeleton of the heart. Now, what did we learn up to now by this structure? That heart has fibrous skeleton, and this fibrous skeleton is made of dense irregular connective tissue. This black fibrous skeleton is made of dense irregular connective tissue. Now what is the function of this whole fibrous skeleton of the heart? Fibrous skeleton of heart has three functions primarily. Yes, who will tell me? Yeah, number one, it provides attachment for the valve leaflets. Attachment for the valve leaflet. Number two, it provides the attachment for the atrial and, yes, it provides attachment points for atrial and ventricular myocardium. Then it provides the base for the attachment of, yes, attachment of major arteries, aorta and pulmonary artery, right? I have seen the people who have studied all the heart without knowing there is something like that, right? So it provides the base for the attachment of major arteries. Then it also works a very important thing, right? That is, it acts as electrical insulator between the atria and ventricle. I will explain more clear. Electrical insulator between atria and ventricle. Let me show you. If I make a section of heart, a very simple diagram, this is your fibrous ring structure. Atria are above it, right? Atria are mounted above the structure and ventricles are mounted below the structure. Please, as good doctor, you must know, atrial myocardium has no direct connection with ventricular myocardium. Ventricular myocardium is mounted below the fibrous ring. Is that right? This is ventricular myocardium. Atrial myocardium is above the ring. So actually all the myocardial cells of the atria, they are connected with each other through gap junctions. Suppose this is one cell, this is another cell, this is another cell. They are having special gap junctions. Suppose this is one atrial cell, this is next atrial cell, and they have special electrical windows, talking points. Every atrial myocardial cell can talk to the next atrial myocardial cell through gap junctions or through the electrical windows, right? So because all the atrial myocardial cells are electrically connected with each other, so we say right atrial and left atrial myocardium is electrically a network, or electrically they behave like a syncytium. Is that right? It is not possible that you produce tachyarrhythmia in right atrium and left is not following the same tachyarrhythmia. rhythm of the right atrium will be the same as the electrical rhythm of the left atrium, because electrically right and left atrium are connected with each other. In the same way, when you come down, all the myocardial cells of right ventricle and left ventricle, they are electrically connected with each other through the gap junctions. Is that right? So it means you cannot say that my patient has left ventricular fibrillation and right ventricle is normal. It's simply not possible. If there is fibrillation in the left ventricle, it has to be in the right ventricle always. That is why fibrillation is said to be ventricular fibrillation, never said right ventricular or left ventricular, because electrically they are connected with each other. All of you must be knowing that the pacemaker of the heart, normal heart, which is SA node, is in the atrium. So electrical current is generated by atrium and spread over both atria. Electrical current is generated by SA node and spread over both atria. Why atria first stimulated electrically? So that atria should complete their contraction and fill the ventricle properly. Only once atria have undergone electrical stimulation, SA node stimulate the both atria electrically. Only when both atria have gone under electrical stimulation and mechanical contraction, only then both ventricles should contract. Both ventricles should not contract before the atrial contraction, and ventricles should not contract simultaneously with atrial contraction. Again, let me repeat it. Atria should pump first and fill the ventricle. Once atria fill the ventricle, only then ventricle should contract and propel the blood into major arteries. Right ventricle to the pulmonary artery and left ventricle to the aorta. Is that right? So for this purpose, the pacemaker is SA node, which is electrically stimulating the both atria first, so atria mechanically contract initially. But when current has depolarized the both atria, then this is the electrical insulator. It does not allow the current from atrial muscle to directly jump to the ventricular muscle. There is only one very special electrical window between the atrial muscle and ventricular muscle. That electrical window is actually AV node. This electrical window is called AV node. So there is only one electrical wire between the atrial myocardium and ventricular myocardium, that is AV node and bundle of his. Now, I don't know, I cannot appreciate nature so much that it is designed so well. Then when electrical impulses come to the AV node slows down the conduction and hold the current for about 0.1 second. AV node hold the electrical current for about 0.1 second so that atria should complete their mechanical action. As soon as atria have emptied well, then suddenly current is released from the AV node and bundle of his into special conduction system to the ventricles, and only then ventricle contract, close the mitral valve, open the aortic. When ventricles contract, close the mitral and tricuspid valve and open the aortic and pulmonary valve and eject the blood into major arteries. Am I clear? So this is one of the extremely important purpose to understand that this fibrous skeleton is acting as perfect insulation between atrial myocardium and ventricular myocardium, and there is only one point through which the current from the upper story can go to the lower story, and that point is AV node. Am I clear? Yes.
So basically we go from the right and fill the right ventricle, from the right atrium to the right ventricle.
No. Yeah, look. Electrically, both atria are stimulated simultaneously. So mechanically, both atria contract simultaneously. Because right atrial muscle and left atrial muscle is electrical network sensitive. So both atria contract simultaneously to fill the both ventricles. Of course, right will fill the right ventricle and left atrium will fill the left ventricle. Once ventricles are filled, by that time, a heart does not have two pacemakers. It has only one pacemaker, that is in the SA node, atria. So first atria go under electrical and then mechanical stimulation, and because current rapidly come to AV node and mechanical activity is little slow. So AV node slow down the current conduction. For practical purposes, AV node hold the current, right? So that both atria should complete their mechanical contraction. Only then AV node will release the current to the ventricular conduction system, so that then both ventricles contract simultaneously and eject the blood into aorta and pulmonary arteries. Am I clear to everyone? So I hope you'll remember this special structure in the heart. It has three very important functions to provide attachments for the valve leaflets, plus it provides attachment for the atrial muscles, ventricular muscles, and the bases of the arteries, region of the arteries, and of course it also acts as an electrical insulator between the atrial myocardium and ventricular myocardium. Fine, no question up to this? Okay. Now we go into detail of structure of endocardium first. Now, if we talk about, let's suppose I take this piece of, what is this? Endocardium. This endocardium, first of all, it is having these cells. What are these cells? Endothelial cells, right? And of course, under the endothelial cell, there must be basement membrane, right? And under the basement membrane or basal lamina, there is subendocardial connective tissue. What is there? Subendocardial connective tissue. Then under that, there will be a big, what is this? Myocardium, right? So actually we can say endocardium is having endothelial lining, subendothelial connective tissue. Okay, we can divide into three. Number one, endothelial cells. Number two, what is this? You simply call it subendothelial connective tissue. Connective tissue under the endothelium. Subendothelial connective tissue. And after that, more deep connective tissue. This is deeper connective tissue, and this deeper connective tissue is called subendocardial connective tissue. What is that? Subendocardial connective tissue. Subendocardial connective tissue. This is very important. The special importance of subendocardial connective tissue is it has small veins. It has small veins and it has some nerves. But a very important point is that in this tissue, there are special conduction system. You know, from AV node, look here now. What was this? This was your specialized conduction system. Let me draw this specialized conduction system. This is from, what was this? AV node, bundle of hairs. From here, right bundle branch and left bundle branch, right? These branches will specially help the electrical current to pass rapidly, or action potential to pass rapidly to all parts of myocardium. This is your, what is this layer? Endocardium, right? And what is here? What is this? Yes, please. Myocardium. The point which I wanted to highlight is that, and there is some, of course, some part of the septum. This is interventricular septum. Upper part of interventricular septum is fibrous, but lower part of the interventricular septum has muscle. Myocardial.
I thought that the circumferential fibers were on the walls of the heart, but it's inside.
Purkinje fibers or these bundle branches, just a minute, these bundle branches, they are moving just under the endocardium.
Okay.
Is that right? They are, or you can say exactly, they are between the connective tissue of myocardium and endocardium. Or some people call it simply that these special conduction system is present in subendocardial connective tissue. Because look, go with this concept. This was what? Endothelial cell under subendothelial connective tissue, and what was this? Subendocardial connective tissue. So this Purkinje system or bundle branches, they are passing through subendocardial connective tissue. So actually, When you talk about the heart, they are in the deepest part of heart. From here, they will give the branches. These branches are called Purkinje fibers. These Purkinje fibers are moving from inner side of the myocardium to the outer side of the myocardium. You're understanding? Right, again, if I make myocardium of left side from this, I dissect this area. So this is the myocardium. Here is the, yes, endocardium. And here is your pericardium. And here is your bundle branch going on, or conduction system. From here, these are the Purkinje fibers. So myocardium is stimulated from inside to outside. Electrical current moves from inside to outside. Why this concept is important? Because when you will watch the lectures or videos related with ECG, this will determine the normal development of ECG pattern and abnormal. That how the current moves through the ventricle. So in the ventricle, current inner part of the ventricular myocardium is depolarized first, and outer part of ventricular myocardium is depolarized late. Am I clear? No problem into this? So these are a few words about endocardium. Another thing, when we talk about the valve structure, let me discuss the structure of a valve also right now. These cardiac valves do not have myocardium. They are just having connective tissue. Okay, let me show you the structure of this is left atrium, this is left ventricle, and this is aorta, right? Let's suppose this is your fibrous base. You remember fibrous base? From here, a connective tissue, aponeurosis type connective tissue will come out and stretch out as, yes, providing a core tissue for the valve. Here it is mitral, and what is here? Yes, aortic valve. Is that right? So actually, if you really see, this is a ring like this, and this is a ring like that. That is why it will stretch out, these rings will open up and valve will fail. Am I clear? Now look, I will just remove it to make the diagram more clear. Now this is connective tissue. This is a dense, you can say, layer of collagen. Is that right? Or aponeurosis like structure from the fibrous ring moving inward to make the valve lie flat. Over it, there is some loose connective tissue here. There is loose connective tissue here, more on the atrial side. This is loose connective tissue here, but this is more on the atrial side. And here also, on the core, you have loose connective tissue more on the arterial side. And then it is covered by, what is it? Yeah, endothelial lining. This is the structure of a valve. Now what you have to really understand here is that this connective tissue, which is loose connective tissue, this is having a lot of elastic fibers, collagen fiber, and lot of proteoglycans. So it is somewhat spongy tissue. It is somewhat spongy tissue. And this black is called, this is called fibrosa of the valve. And this connective tissue is called spongiosa of the valve. Spongiosa of the valve. So valve, in the core of the valve, dense connective tissue is fibrosa of the valve, and over that there is relatively loose connective tissue which is called spongiosa of the valve. Fibrosa of the valve provides the strength to the valve, and spongiosa of the valve cushion the valves when they close and help the valves to dampen or reduce their vibrations at closure. Is that right? And of course, endothelial lining is around that structure. Another question. These cusps of the valve, are they vascularized or not? They are not vascularized. They are very thin. In my diagram, they look very thick, right? So actually, valve cusps are basically avascular structure. There may be small vessels only at the base of the valve. In the base of the valve, there may be small vessels normally, right? Otherwise, most of the cusps of the valves don't have vascularization. But when repeatedly during diseases they get inflamed, then they may develop neovascularization. For example, there is a disease called rheumatic fever. Have you heard of rheumatic fever? What happens in rheumatic fever? Okay, let me tell you very briefly. You will study that in detail in pathology. In rheumatic fever, what really happens, that someone who is suffering with a special type of sore throat by a special type of bacteria. These are called Streptococcus, Beta hemolyticus, Lancefield group A. Not every sore throat produces problem. In about 3% of the population, if they suffer with Streptococcus, yes, Beta hemolyticus, Lancefield group A, rheumatogenic strain. If the specific type of bacteria attack, then of course normally what happens, whenever this bacteria will attack, look here, this is your immune head office. Whenever this bacteria attack, bacterial antigen will be processed by the immune system and there will be immune response, and that immune response like antibodies and reactive lymphocytes will destroy bacteria. This is what happens normally, that bacteria producing sore throat, immune system is activated, an immune component attack back the bacteria and destroy the bacteria, right? And you become okay. But in 3% of the population, problem is having an unfortunate complication. In 3% of the population, one of the antigen of bacteria is very similar to the antigens in their connective tissue of the body. Some of the antigens of bacteria are very similar with antigens present in their connective tissue of the body. So, when immune system is activated against the bacteria, unfortunately it reacts against their some part of connective tissue. Again, what is happening? Normally, if bacteria attack my throat, my immune system should process the antigens and build an immune response and destroy the bacteria. And normally immune system should destroy the bacteria and don't disturb our own tissue. But in 3% of the population, if this special type of bacteria is producing sore throat, their immune system, when it builds up the immune response, of course it does destroy the bacteria, but unfortunately, due to some molecular mimicry between the bacterial antigens and their own connective tissue antigens, the immune system, which is primarily activated against the bacteria, cross-react against their own connective tissue and it attacks their connective tissue, and it may produce attack on the joints, produce polyarthritis. In the skin, it also produces lesions. It also produces cardiac lesions. Central nervous system, it produces chorea, and in subcutaneous tissue, it also produces nodules. So in these children, it's more common in children between 5 to 15 years old. That whenever they get, in these specific children who are predisposed to this complication, whenever they suffer attack by this bacteria, first they develop the sore throat. After 2 to 3 weeks of sore throat, they develop pain in multiple joints, they develop skin lesions, subcutaneous nodules, they may develop chorea and cardiac complication. All these complications as a set are called rheumatic fever. What is it called? Rheumatic fever. So in rheumatic fever, one of the tissue which suffers is cardiac connective tissue. It may attack endocardium, myocardium or pericardium, but right now we will concentrate only on valve. So what really happens in these children, immune component attack the valve. When they attack the valve, Immune system, when it is reacting with the connective tissue of the valve will become injured and inflamed. And when endothelium is injured, on injured endothelium many platelets and fibrin will deposit, right? And we say small vegetations are formed. Platelet and fibrin composition, vegetations are formed on injured valve surface. So these children, whenever they develop sore throat by that organism, they have a tendency that their sore throat will be followed by rheumatic fever, and during the rheumatic fever, they may develop valvular inflammation, and if valves get inflamed, later on when bacteria disappears, immune system is no more stimulated, immune attack to tissue also go down. But when the valve were injured during the acute fever, when valve were injured, platelets stick to this area. When this area will heal, platelet will produce growth factor, and many fibroblasts and blood vessels will grow in this area, and they will produce lot of collagen and scarring of the valve. So valve will become little bit deformed. It will become deformed. Now, because this type of bacteria will be attacking again and again if you don't do proper treatment, so this child will develop repeatedly rheumatic fevers, and there will be over the years many episodes of valvular inflammation, vegetation formation, and followed by healing and deformation of the valve, right? Especially if you look at this valve from the top, it looks like this. So with every attack, some vegetations are formed here, platelet vegetations. When these vegetations heal, the sides of the leaflet become fibrotic and sticky. Next attack, after 5 months, another episode of fibrosis of the valve. Then after 2 years, another attack. So over the years, the valve leaflets become distorted, vascularized, fibrosed, deformed, and sticky to each other, and eventually valve mouth will become too much wide or too much narrow. Narrow. It is like a fish mouth. Fish mouth deformity of mitral valve. Right? This is a very classical problem with these valves in those children who suffer with rheumatic fever again and again. And when mitral valve become narrow, we say mitral valve is stenotic. Right? So this rheumatic fever, rheumatic heart disease more commonly produce complications in mitral valve, less commonly in aortic valve, and least commonly on the valve on the right side of the heart.
What else could be a cause of mitral valve stenosis?
There can be many causes, right? There may be congenitally malformed valve and having the mitral valve stenosis, right? But most common cause of acquired mitral stenosis is rheumatic heart disease. Is that clear? Yeah, that is mitral degeneration with calcification, right? That is less common phenomenon. That type of degenerative changes in the valve are more commonly seen in aortic valve, because aortic valve is under high pressure, right? So operating at between the aortic pressures and ventricular pressures. So over the age, as arteries become hardened, in the same way aortic valve also become deformed. Am I clear? Right. Another thing with these valves, that sometimes bacteria or microbial agents, they get lodged here and they proliferate here and they make infective vegetations. And if you get infective vegetations here, the condition is called infective endocarditis. And sometimes infective endocarditis can be so severe that so much aggressive, you can say war is going between bacteria and neutrophils, and so much destructive enzymes are produced, valve may rupture, and that may lead to severe cardiac failure. Is that right? So these were few clinical correlates related with the endocardium. Let's have a break. So we were talking about the valves in the heart, and another important thing is the valve between the atrioventricular system. They are large valve, right? For example, mitral valve is quite a large valve, and tricuspid valve is also very large valve. But aortic valve and pulmonary valve, right? They are small valves. Again, so because their ring is from here to here, but here aortic valve ring is very small. Here again, for tricuspid there is a very big ring, but for pulmonary there is a small ring. So what we see really, that AV valve, that is mitral valve and tricuspid valves, are larger valves, and output valve, which are aortic valve and pulmonary valves, are small valves. But there is one problem, that not only AV valves are very large, they are very thin as well. So they are not very strong valves, right? Due to this reason, there is always a problem. The problem is that because mitral valve is very thin, right? So there is always a problem that when ventricle will go at the peak of its systolic pressure, when ventricle will contract at the top, pressure here may become about what is the maximum pressure in left ventricle? Up to 120 millimeter of mercury, right? Systolic pressure may go. Now, when ventricles start contracting, mitral valve leaflet will close. But as ventricle keep on building the pressure, it opens the aortic valve and start ejecting the blood into aorta. During this phenomenon, when ventricular systole is going on, blood should not be allowed to fall back into aorta. It should only move one way forward into arterial tray. Because left ventricle generates very high pressure to push the blood into systemic arterial tray, so there is too much pressure on mitral valve. And there is every chance that mitral valve, being a very large area but thin valve, leaflet, so there is every chance that it may evert backward and blood may regurgitate. To prevent that, nature has provided with a very special apparatus that there are small tendon-like structures here which are called chorda tendineae. And these chorda tendineae, at the base of them, there are, what is this? Some muscles coming from myocardium which are inserted or attached with the chorda tendineae. These muscles are called, they are also having endocardial endothelial cover. Now, these muscles are called papillary muscles. They are called papillary muscles, and these connective tissue cords are called chorda tendineae. So what really happens, when left ventricle contract, these muscles also contract, and they keep these cords taut, and these cords don't allow the valve to evert backward. So they prevent the regurgitation of the valve or incompetence of the valve, right? This is called chorda tendineae papillary muscle apparatus. This is very important apparatus because if there is dysfunction in this apparatus, valve will regurgitate or balloon into aortic area, in atria. For example, if papillary muscle is very long or chorda tendineae is very long, this valve during the ventricular systole, valve should come and stay like this. But if chorda tendineae is loose or muscle is loose, then it will move a little upward. This is called mitral valve prolapse. What is it called? Mitral valve prolapse, when there is undue ballooning of cusps of mitral valve into left atrium. So normally when ventricles start contracting, valve should come together and move like this. But if chorda tendineae or papillary muscles are not tight enough or taut enough, or valve has very large surface area, right, then it will slightly balloon upward. This is called mitral valve prolapse. But if mitral valve or chorda tendineae are very, very loose, then at the peak of contraction, this will regurgitate and blood will go backward from left ventricular cavity to the left atrial cavity. We say there is mitral regurgitation. This type of problem is seen commonly under two situations. One is when there is infective endocarditis, infection, severe infection in the endocardium, and if infective process, right, or bacteria destroy the cord, or they destroy the attachment of cord with the valve, or they destroy the muscle, right? So sometimes in severe acute infective endocarditis, infection may disrupt this apparatus. Either it destroy the cusps or destroy the cord or the muscle, mitral valve will start regurgitating. Another common situation is in patient with myocardial infarction. In patient with myocardial infarction, of course, there are vessels which are bringing blood to myocardium. Let's suppose this vessel is blocked. Then this area will become infarcted. And if that part of the myocardium become infarcted on which papillary muscle was mounted, papillary muscle may break away from infarcted area. And if it really breaks away, just with one contraction, the moment he breaks away, there will be severe mitral valve regurgitation. Even in some cases, the coronary blood flow is so less that papillary muscle itself may undergo infarction, right? So, in ischemic heart disease and in infective diseases of endocardium, this papillary muscle chorda tendineae apparatus may be disrupted and may produce mitral valve regurgitation. Am I clear to everyone? Right, so we have discussed about endocardium and the valve. Let's talk about myocardium now. Yes.
Regurgitate back into the atrium. Can that go back into the pulmonary vein?
Yeah, if there is regurgitation and ventricle push the blood back to the atrium, right? Pressure in the atrium become very high. Then from the lungs, blood cannot come into left atrium. So pressure in the pulmonary circulation goes up. And the weakest point in the pulmonary circulation are pulmonary capillaries. So when pressure in the pulmonary capillaries become very high, fluid oozes out. When fluid goes out, the lungs become heavy and boggy. They become wet lung, pulmonary edema. And it is difficult to breathe through that. So patient develop dyspnea, difficulty in breathing. Anyway, let's come back. So what we are talking about is now myocardium. Generally, all the myocardium is classified as general myocardium, which is mostly atrial and ventricular myocardium, which is concerned with the contractility function. Most of the atrial myocardium and ventricular myocardium, they are having main function of contraction, so that blood from atria go to the ventricle, and when ventricular contractility is, blood from the ventricles goes to the main outlet arteries. Then there is specialized myocardium, myocardial cells. These are modified myocardial cells. There are two types of specialized myocardial cells. Some have specialized, they have specializations in electrical properties, right? Some specialized myocardial cells which have special electrical properties. For example, some of these cells can act as pacemakers, some of them can act as electrical current conduction pathways. And then some of the specialized myocardial cells work as myocardial endocrine cells. The most important hormone which is produced by the myocardial cell is atrial natriuretic peptide. Have you heard of it? Atrial natriuretic peptide. What really happens when in your total blood volume is too much, when you have, for example, right now, if I start giving you very rapidly intravenous fluids, right, and your blood volume become too much, then what will happen? That venous return to the heart will be more or less? More. So atria will stretch out. Whenever atria stretch out, some of the atrial myocardial cells release atrial natriuretic peptide. Again, what really happens whenever your body is fluid overloaded, especially the blood volume is too much, right? The venous return to the right heart and the left heart both become too much. And when atria are distended or stretched out, right, then certain atrial cells release atrial natriuretic peptide. Now, what is the function of atrial natriuretic peptide? Atrial natriuretic peptide, number one, it will go to kidney, and in the kidney, suppose this is nephron, urine forming tubes, right, and this is afferent arteriole, here are glomerular capillaries, and this is efferent arteriole, and efferent arteriole. Number one, atrial natriuretic peptide work on efferent arteriole and it become constricted. When efferent arteriole become constricted, then blood is coming to the glomerular capillaries but cannot leave the capillaries easily. Pressure in glomerular capillaries become high and fluid will more rapidly go to the nephron. So we say glomerular filtration rate is increased. So what ANP is doing, atrial natriuretic peptide, that whenever there is fluid overload in the vascular system, venous return to heart become more, both atria stretch out, and when there is more stretching of the atria, they release atrial natriuretic peptide. It does many functions. One function is, end result is it will expel the water and sodium out of the body. How? It constricts the efferent arterioles, so pressure in glomerular capillaries become high and more glomerular filtrate is made. So fluid will pass through tube more rapidly. So less fluid will be reabsorbed and more fluid will be lost into urine. Secondly, it also acts on the medullary part of nephrons and reduces the sodium reabsorption. So what really happens, the filtered fluid along with extra sodium will be lost into urine. Because excessive sodium is lost into urine, we say this hormone is producing natriuresis. And because water follows that, so secondary to natriuresis, this hormone produces diuresis. This is number one function. Number two, this hormone from juxtaglomerular apparatus, atrial natriuretic peptide reduces the production of renin. If kidney is producing less renin, then yes, who can tell me what will happen? Who knows the renin, angiotensin, aldosterone system? Renin normally convert a substance coming from liver. From liver what is coming? Angiotensinogen. So renin normally convert angiotensinogen into angiotensin 1. Angiotensin 1, when it passes through the lungs capillary, it converts into angiotensin 2. Now listen carefully. When atrial natriuretic peptide is more, it reduces the renin production. So conversion of angiotensinogen into angiotensin 1 become less. Then conversion of angiotensin 1 into angiotensin 2 become less. In the blood, angiotensin 2 is less. Angiotensin 2 has many functions, but two functions are most important. Angiotensin 2. Number one function is, by its name, angiotensin. It produces tension in the vessels. So when angiotensin 2 is less, right, less angiotensin 2 cannot constrict the vessels dilate. And when veins will dilate, venous return to heart will be less. Is that right? Number two, angiotensin 2 not only will relax the blood vessels, plus it will reduce, one of the functions of the angiotensin 2 is that from adrenal gland, adrenal gland cortex, it produces aldosterone. So when angiotensin 2 is less, then aldosterone is less. One of the functions of aldosterone is that from this part of the nephron, it helps in sodium and water reabsorption. So when aldosterone is less, then aldosterone mediated salt and water reabsorption cannot be done, and this will be lost into urine. So in this way, what angiotensin, atrial natriuretic peptide is doing, that it is produced by released by the atrial cells into circulation when both atria are distended with excessive amount of fluid. So they should orchestrate those biological actions which should deload the sodium load from the body, they expel the sodium and water out of the body. One way is that they simply go to the efferent arteriole, constrict them, so there are more glomerular filtration, most loss of the fluid and sodium into urine. Number two, they inhibit the renin, angiotensin, aldosterone system. So aldosterone mediated salt and water cannot be retained. So salt and water is lost. Number three, atrial natriuretic peptide inhibit the release of antidiuretic hormone. Antidiuretic hormone is released by the posterior pituitary. So antidiuretic hormone become less. What is the normal function of antidiuretic hormone? Normal function of antidiuretic hormone is, it is antidiuresis. Normal function of antidiuretic hormone is, it reabsorbs the water. It helps in reabsorption of water. When atrial natriuretic peptide reduces the release of antidiuretic hormone and antidiuretic hormone become less, then these cells will not reabsorb the water, because here the water reabsorption is antidiuretic hormone dependent, so extra water will be lost. In this way, whenever atria are overstretched, right, or over distended with the high volume of the venous return, they simply let the sodium and water get out of the body through the kidneys, so that total blood volume become less and venous return to atria become normal.